priority three is um, to make it more of a organizational level change, right? How to build capacity. Now, how they understand it, they want to implement, but how to really incorporate it in a system-wide initiatives, how to really bring in the, this is how I see it, how to really bring in into their fold and bring and implement all these things that they have learned, how to really operationalize um, all the things that organizations want to do. Is that what your understanding is?
It is, and I think health equity is so challenging, and I just noticed that there's a lot of comments around even like recognizing different cultures and cultural adaptation and language. And I know as someone who worked on the operations side, this was always difficult, really having an authentic experience, being able to identify these populations where there are disparities and being able to activate any type of intervention. I know Persivia talks a lot about artificial intelligence and machine learning, and so I was hoping that you could talk to us a little bit more about how would someone, first of all, what is artificial intelligence, and then how someone might use it to better inform their health equity plan so that our listeners don't have the challenges, right? Like I've experienced in the past, like I just shared with you.
Great, thank you. Artificial intelligence to me is whenever we use help from machine learning and computers to guide us to do the right thing in healthcare. So in this domain, it would be that how can we really make this shift where we addressing the health issues, keeping equity in mind, not just addressing them in silos. So making a whole plan to reach out and address the health issues, including their social needs as well. And artificial intelligence can play a big role in that. It can, first of all, it can start with giving us um, analysis or views into where we stand today as an organization, how many social diagnoses that we have, what percentage of my population has, for instance, food insecurity or housing insecurity, what is the health literacy level. So this window can come from AI because the Z codes have just been introduced. There's so much unstructured data, so we can get help from AI to understand where we stand today as an organization. That's the first step, because now we have to move forward and say, okay, now we want to be inclusive and keep patients' needs involved in how we move forward. And that's not traditionally the role of a healthcare organization. Basically, we think of it as acute care, somebody gets sick and get the healthcare, or an outpatient facility where we continue to provide care. But again, the same theme of taking care of the patient is very, very critical, that this is a longitudinal caregiving. This is not just one instance of providing care. So this concept of taking care of the whole patient, I think, is really evolving. And the recent physician fee schedule, which was finalized yesterday, also has codes for SDOH assessments. And taking care of this patient as a holistic manner. I think there are many codes which are introduced there as well. So I think this is a big change we are seeing, and AI can definitely help, as I said, first of all, to analyze and help us understand where we are. And then again, there's so many different ways. For instance, it can help us to create personalized care plans. So AI can help us looking at the individual patient data and make sure that it's tailored to that patient's unique needs. AI can help us even construct some of these large language models like chat gpt. They can help us construct these messages, which can then again be reviewed by the care managers. But instead of writing it from the scratch and doing 5 maybe in a day, now they can review 500. So it can really help us to reach out to many, many more patients, have these very personalized care plans. So not just looking at diabetes, because a person who has food insecurity, housing insecurity, and has A1C of greater than 9% is in a very different position than an executive who may be going through depression and then and then not taking care of oneself. So these are very different, same clinical picture, but very different way to approach these individuals. So now we can bring all that information and make an outreach and a care plan which exists for this patient, not just these encounters. So I think all this can be done by AI.
So I love so much information there, and
Mhm.
talking about priority three, in looking at some of the particulars, they talk about making sure to bring in groups, right? Not to leave out or exclude particular groups that might be disenfranchised, if you will. And so, how can physicians be more inclusive? And I love that you took us from that whole patient population view, because I agree with you. You really have to understand who your population is. And a lot of times, we forget to really, I think, turn the table and understand. You mentioned health literacy, which I think is one of the biggest predictors of health outcomes and how someone's going to take up their health care. And so if your population is not very well versed, maybe they refer to diabetes as the sugars and not really having a good understanding exactly what it is, I think is so important, and I think can help, inform physicians. You also mentioned a couple of other things though, and we know that health equity is challenging for physicians to do this work. I do think technology will help ease the burden because it's not easy, right? There's a lot that they're already having to do. And so adding this in, I think, makes it more challenging. But I'm curious, you talk about machine learning and you talk about AI, and I know that that's all the buzz in our industry. And I would love to hear, because I happen to have a lot of admiration and respect for what Persivia does and for, your guys's model. I would love to hear more about what is it about the AI that Persivia has that makes it so unique, that will help physicians? Because a lot of, the industry is really booming with all this technology. But what is it that Persivia brings to the table with its AI and its machine learning, that can even further, right, physician success when it comes to identifying SDOH, developing actionable health equity plans that really make a difference?
Persivia has a digital health platform which can really provide insights at the point of care or point of need for our providers, for our care managers, even for our patients. And they are we are able to provide those because we have very deep expertise in machine learning and artificial intelligence. But the point is to bring this information requires certain um, expertise in what I would say data management as well as evidence management. So these two things come together in Persevere. In our data fabric, it's a very important concept that we have what we call our semantic sets or a way to tag the data. These then becomes dual connectors. They just don't connect to the data. They also connect to evidence. And we have thousands of these evidence-based insights. So at every point in the data fabric, we have these semantic sets which allow us to really make sense of the data and to feed it into these models and leverage the evidence which comes along and provide that at the point of need, and we leverage it at every point. So we don't just hang a, a case of use case of AI at one end and say, okay, we will leverage large language models at this aspect and send it to the patient like our competitors do. This data fabric, these semantic sets, these portals into evidence-based medicine and these connectors of data are underlying our entire digital health platform. That is why we can bring this information to our providers, to our care managers, to our patients at every point with evidence and with data insights coming from Bayesian rule engine that we have or machine learning and AI.
I think that's so important. I know, the we hear a lot about the dark side of AI, and I think that there's a lot of concern about data getting in there that would be inappropriate, right? That would be applied to a patient, and then, it's like the machines take over, and you'd never get rid of it. And I know in standing up platforms in the past, in my experience, there was always the concern that there would be too much noise, right? That physicians would just be overburdened with too much information at that point of care, or health plans, right? And so I love that, that you mentioned that yours is different and that you're looking at these semantic sets. I think it's important too to note that you're a physician as well. And so have that lens and can really apply that. Um, when you were developing your AI, or maybe you could even take us through what are some of the things that you're doing today to make sure that that AI is avoiding that noise, if you will, making sure that physicians are getting the appropriate messaging at the point of care so that they can treat the whole patient. Those care management teams are getting the information that they need to do the work that they need to do. What types of things are you doing to stay current so that your AI, right? I know you said that it's different, but how do you continue to look forward and make sure that you're providing the best tool available?
It has a nerdy answer, Shannon, that we have these semantic sets which are pre-formulated, and to depend on, and there are thousands of them, and they are developed over the last decade, keeping this clinical quality analytic sense in mind. So we know what diabetes is for analysis, as I often take the example of when to include gestational diabetes, when to include metformin or not to include that. It is almost impossible for that noise to go away if you're going to let AI build its own value sets like it is expected to do. So that noise stays there. Our way of combining this semantic sets along with machine learning models takes away the noise and keep our information very accurate and to the point, so that the providers feel comfortable that behind this is a solid science of these semantic sets. They can even look at them and say, okay, I understand when Persivia calls something ABC, what it means, rather than this black box of complete AI where they don't know what's going on. So I think that's a very big advantage, and our providers like that. Second biggest advantage that we have is that we are bringing in the evidence-based medicine insight, the insights from thousands of medical journals of what we need to do at the point of care. So it's not just the AI which is predicting for that patients. We also bringing actionable information and combining evidence-based medicine. I think that's also a very unique capability that we have. And that's not just for the providers, but it's for the care managers, for the family members, for the patients on what does the medical evidence say to do in this particular condition. So these are not just thousands of pages of guidelines. This is looking at the patient, having that AI working at a patient level, not just at a population level. I think that is also very, very unique in Persevere. It's a decade of work. As you said, I'm a physician, so I really wanted to improve our patients' health. So this is a labor of love, and 10 years or more of working 24/7 of our team, which is very dedicated. And that's why I think we are having this appreciation now and an acknowledgement in the industry that yes, we are doing something which is different and which is much needed.
So I love that, 10 years of or more, right, of hard work, you being a clinician, bringing those extra elements to the work that you do, I think is so important. And, when we look at all the extra work that CMS and others are asking physicians to do, I love that you've already done most of that work, right? Like um, I see it as, you've really lifted some of that burden for our care teams to be able to really dive right in and have, have an effect, have an actionable effect, and be able to trust the information that's being presented to them, which I think is, has always been a challenge, at least from what I've heard in working with physicians in the field. I think the other important point to note too is that, when we going back to priority 3, these are challenging population sets, typically have not engaged in a way that has done anything right to improve outcomes. That's why we focus here. and thinking about being able to provide that information, and like you said, being able to reduce the noise that someone might experience at that point of care is also important. I don't
Absolutely.
know.
No, that's great. So that's, I agree with you, Shannon, that we have to, this taking care of this population is very challenging. And to the point how, and our healthcare systems are not set up to provide the full care that these folks need. That is why we need platforms which are more of a collaborative care platforms, because you need to bring faith-based organizations, the community organizations. You can't just have this encounter between a provider and a patient. Now we have to think of it in the consensus of a collaborative care type of a paradigm. So it's a paradigm shift, right? It's not just, first we thought of team-based approach where we brought in nurses and PAs, but now we are going beyond that, and we are saying let's organize around the patient and bring in the community resources and manage them, which means that we need to track them. We need to track that we had warm handoffs with these different faith and community-based organizations, that they were actually followed up and they got the support that they needed. So here also AI and these platforms like ours can help to manage these patients, and it can't be done in an EMR.
Again, love the identification that all of this movement, in light of all of this change that we're being asked to accommodate, right, in healthcare now. And so moving from that team-based approach to that collaborative approach. And agree with you, again, looking back at priority 3, just the nuance that's going to be required to ensure that, these populations that have been identified and solely identified as ones that CMS is concerned about being on the periphery, not being addressed. Perhaps, physicians are de-incentivized for caring for them, making sure that they're brought to be part of that clinical model, and that change is actually being afforded. I think is so important, and absolutely agree with you. It can't be done with generalized tools. You have a very specialized mission, and so you need a very specialized tool to help you be successful, and really need something that's been vetted. I think that there's a lot of new products that are out there. There's a lot of folks claiming to do AI, but I appreciate you sharing with us exactly what Persivia has done, because I think that that's where the conversation needs to move to, is what exactly is AI, and then how do we as leaders on the operational side, how do we evaluate it to know that we're getting something that's going to actually help us be successful and pardon the cliche, but move the needle as we're being asked to do. And so really appreciate your insight.
Great, thank you. Another thing I want to add to that is that the physician fee schedule, which is finalized yesterday, also has change in assignment methodology for the ACO, and now we can, starting Jan 1, 2025, the window for assignment has moved from 12 months to 24 months, and I think that's really good, even for these marginalized populations. CMS is thinking that this will add 1 million more of our beneficiaries to ACO population. And I think many of them may be marginalized one because they may not have access to healthcare. So this is some change which is very welcome. Going back to your comment about what to seek in these platforms, because everybody's talking AI, make sure it's authentic. Make sure they explain to you the science behind that. Like I brought forward the semantic sets and how they live inside the data fabric and underneath the entire platform, that they are not just some use cases which are hung on at one end of the platform, but actually the whole platform can leverage these insights and they can provide them at the point of care, at point of need for every role that we have in organizations. So I think that's very important to ask these deeper questions, that how does it work? How do you construct these just having a black box answer, we use decision trees or AI modalities. I think we need to go deeper than that.
I appreciate you bringing that up, and I would agree with you. I think that, it's a very complex problem, and there are times, we talk about it in a way to simplify it so that it's, so that we can absorb the issue. But I don't know that that necessarily addresses, all the components, and just even, you're mentioning the widening of the how beneficiaries can be attributed. I know as an operational leader, when I hear that, while it's moved from 12 to 24 months, while it may widen it as far as patients that can be part of an ACO, where my mind goes immediately is that there are patients that perhaps aren't getting in with a regular basis. And so while they may be identified to you, the other component, right, of these programs is to also make sure that you're managing care, and you're also, if you've assumed global risk, right, that you're on the hook for total cost of care. And so it's really easy to have someone aligned with you early on have exacerbation that then causes exorbitant cost later on down the road that you don't have a lot of time. So I see the positives to it. I'm usually not very pessimistic or cynical, but I can see where that could be potentially be a challenge. And so just want to encourage our audience out there, if you're a risk-bearing physician group, if you're a health plan that's working with a risk-bearing physician group or a vendor, right, that you want to make sure that you're aware of this, that it's not just about, hey, we got a lot of new beneficiaries. We now have that many more people to manage, and we have a longer window to manage. And so it's very easy to have, that patient go from not having any cost to having cost and really not having sight of it because you haven't seen that patient. And so I think it just builds the argument for tools like yours, especially, we've been talking about looking at the individual patient, but looking at the population as a whole. And so it builds the case for really understanding. In fact, I know that that was a component, that we wanted to talk about, and it's part of the quality measures, right, for ACO, is that you not only recognize the conditions of your patients, but you also are aware of those that have a high propensity or a high likelihood of having an admission to the hospital. And what are you doing, right, to get in front of that and potentially treat them at a different site of care, maybe a less costly site of care, just as effectively, right? So not suggesting that it's lesser care, but more appropriate care. And I think that, tools like we're talking about and artificial intelligence can do that. So not just looking at the individual, but the population as well.
Absolutely. And to predict the risk of readmissions, to predict the risk of these high cost events occurring later, which are not only costly, but also impact the care of the patient. So if we can catch these health issues early on, and AI definitely helps us there, then it's good for the patient and good for the organization.
Absolutely. Well, I love it. I just think that, there's so much development coming out in our industry. It's really challenging to stay on top of it all and to be able to move. And I think we're asking a group of individuals, a group of professionals, our physicians, to bear a lot of the burden. And I know that it's because we have the how can I say this? I know it's because we feel that they have the relationship with the patients. They're well-equipped, trained individuals, caring and compassionate. And so, where else can we address these types of issues? And we know that without addressing, right, social determinants of health and, things like you mentioned, health literacy, transportation, food security, housing security, if we're not taking care of those needs first, it's very difficult then to focus on taking care of one's diabetes or cardiovascular health. And so I think that tools that can mitigate the space, be able to move, right, that they're fluid and agile, AI tools that can move from looking at a population as a whole to an individual from reducing noise, from working across the care team, are all really important and things that one would need in order to be successful as healthcare continues to evolve.
Absolutely. Agreed. Thank you.
Thank you.